Good evening, friends. Today I am going to discuss a very important topic in anesthesia, that is obstetric hemorrhage. Anesthetic management of obstetric hemorrhage is very important, and it's a very important question in final year MD anesthesia examination. So, what is obstetric hemorrhage? As the name itself indicates, it's a bleeding per vagina uh, in the peripartum period. So, obstetric hemorrhage epidemiology, it's a 1 in 1000 deliveries, and it is a preventable problem, and mortality is very high. It requires very prompt recognition and proactive action. It's a matter of team planning, coordination among the multidisciplinary coordination, and proactive approach. So, obstetric hemorrhage is mainly divided in two categories: antepartum hemorrhage and postpartum hemorrhage. First, discuss with antepartum hemorrhage. According to RCOG, antepartum hemorrhage is defined as bleeding per vagina after the 24th week of gestation or 24th week of pregnancy, and the common causes of antepartum hemorrhage are placenta previa, placenta accreta, placenta abruptio, trauma, thrombin like coagulation disorders, septicemia. So these are the common causes of antepartum hemorrhage. Now, what is the postpartum hemorrhage? It is divided into two parts. One is primary and secondary. Primary is or early PPH. It's a late PPH. It's within 24 hours of delivery. Bleeding per vagina occurring within 24 hours after delivery, and it is 24 hours. Secondary PPH is defined as bleeding per vagina occurring after 24 hours to 12 weeks post delivery. Primary and secondary. The amount of bleeding: vaginal delivery, normal bleeding is less than 500 ml. It's a usual bleeding, and LSCS or cesarean section less than 1 liter is considered is normal. Above 500 ml in vaginal delivery and more than 1 liter bleeding after the LSCS or lower cesarean segmental cesarean section is considered as obstetric hemorrhage. What are the causes of PPH? The causes of primary PPH or secondary PPH. Now, causes can be divided into two parts under the following headings: 4 T's. T is tonicity, T is trauma, thrombin, and tissue. The tonicity, 70% reason of obstetric hemorrhage is uterine atony. Trauma over the vulval areas during the large head delivery, vaginal delivery, episiotomy, trauma during LSCS surgery. Thrombus means coagulation disorders, PTINR problems, and tissues, abruptio placentae, placenta previa, accreta. These are the tissue problems. What are the risk factors? The common causes for as we know, the common causes for antepartum hemorrhage is placenta previa, placenta accreta, placenta abruptio, trauma, sepsis. Similarly, the common causes of early PPH, retained product of conception, and sepsis. These are the common causes for peripartum hemorrhage. What are the risk factors? Risk factors of obstetric hemorrhage or postpartum hemorrhage. Can be divided in 4 T's. T is tonicity, atonic uterus. It's because of increasing age of the mother, polyhydramnias, multigravida, obesity, diabetes, hypertension, comorbidities, history of preeclampsia, history of large baby delivery, history of preeclampsia during previous delivery, and previous history of PPH, previous history of prolonged labor. These are the reason of atonic uterus. Trauma during LSCS surgery, trauma to the tissues, and during episiotomy, and during the vaginal delivery of the large head. Thrombin problem, coagulation disorders, and PTNR problem. And similarly, the tissues, as I already told you, placenta accreta, placenta previa, and abruptio placentae. Now, before proceeding further, some brief discussion over the few terms like placenta previa. What is placenta previa? It is the low-lying placenta, and sometimes it covers the os, sometimes it covers the complete os. So, low-lying placenta, it's a very dangerous cause of bleeding or PPH. It can be categorized into 4 categories. One is low-lying placenta. Second one is low-lying placenta near os. It's around 2 centimeter near os, and partially covering os, 3rd degree, and complete covering os. Complete os is covered in the 4th grade. So, is a placenta previa. The dangerous placenta previa or risk of massive bleeding is type 2 posterior placenta, 3rd degree placenta, and 4th degree placenta previa. This is dangerous type. This is uterus, this is cervix, and this is os. If low-lying placenta, grade 1. If nearer to os, grade 2. Partially covering, grade 3. Full covering, grade 4. Placenta accreta spectrum. Placenta accreta spectrum. It is the chorionic villi penetrating the myocardium, penetrating the myometrium or uterine muscles. Placenta accreta, chorionic villi reaching up to the myometrium. Placenta increta, chorionic villi crossing into the myometrium, and placenta percreta, chorionic villi crossing the myometrium and going other side, crossing the serosa to the urinary bladder, sometimes the abdominal organs. Placenta abruptio. What is abruptio placenta? It is the premature separation of placenta between 20th week to the term. Premature separation of placenta within the 20th week to the term, which leads to less placental coverage to the fetus, which leads to decrease in nutrition and tissue hypoxia in the fetus, which leads to risk to the fetal loss. Risk of fetal loss. Placenta abruptio can be classified into 4 types: 1, 2, 3, and 4. One is no visible vaginal bleed, slight vaginal bleed, mild to moderate vaginal bleed, and severe vaginal bleed. Mild, moderate, severe vaginal bleed, slight, mild, moderate, and severe. Slight is less than 750 ml, 750 to 1500 ml, 1500 to 2000 ml, and more than 2000 ml. It is also classified into concealed, revealed, and mixed. Concealed is of rare type. Now, what is the management of obstetric hemorrhage? First, meticulous preparation, team information and coordination, and call for help. ABC of resuscitation. Head down tilt. Two large bore cannulas. Plenty of crystalloids, colloids, and blood. If time permits, arterial line, central line. Monitoring, hemodynamic monitoring. If time permits or hands are available, we can go ahead with the hemodynamic monitoring. Crystalloids has to immediately started. We have to give at least 2 liters of crystalloid till the blood arrives, and we can start colloid in between up to 1 liter. Maximum dose is 20 ml per kg body weight per day, not more than that. And blood has to be given PRVC, platelet, and FFP 1:1:1 ratio. Criteria of starting blood transfusion: if platelets are less than 50,000, INR more than 1.5, and fibrinogen is less than 150 milligram per liter fibrinogen, and risk of bleeding, and hemoglobin less than 8. Treatment measures: uterine massage, bimanual uterine compression, balloon tamponade creation, using the Rus balloon, B Lynch suture, and ligation of uterine artery and internal iliac artery, hysterectomy. Drugs for the treatment of obstetric hemorrhage: syntocinon, the synthetic oxytocin, 5 international unit, slow IV, and then because rapid injection will cause hypotension and bradycardia, vasodilation, can be repeated once more, 5 international unit, and then infusion 5 international unit and 5 international, then infusion 30 to 40 units in 500 ml NS at the rate of 125 ml per hour. Argometrin methargine, dose is 0.2 milligram or 200 microgram, slow IV, 8 hourly or IM, and adverse effects are nausea, vomiting, vasoconstriction, marked rise of blood pressure, avoided in preeclampsia, cardiovascular disorders. Problem is accelerated hypertension, tachycardia, restlessness, chest pain, breathlessness. These are the problem with the methyl ergometrin, so it has to be given very cautiously. Carboprost is prostaglandin F2 receptor agonist. It causes uterine contraction, 250 microgram intramuscular, can be repeated 8 times every 15 minutes, and it causes bronchospasm. So asthma cases, it has to be avoided in asthma. It can cause hypoxia, so be vigilant. Misoprostol, prostaglandin E1 analog, dose is 1 milligram rectally or per vaginally or per oral. Tranexamic acid, 10 to 15 milligram per kg body weight. Mechanism of action is stop the conversion of plasminogen to plasmin. Plasmin is the region of dissolving the clot. Dissolution of clot is the work of plasmin. So if we stop this pathway, it will help in stopping the bleeding. The obstetric hemorrhage is not only the problem with the hemorrhage only. The pathophysiology involves two kind of problems: the uterine tissue destruction or endothelial damage. During all those risk factors, as we have discussed, these type of problems occur like uterine tissue destruction, endothelial damage, stress, which lead to two pathways. One pathway leads to the coagulation cascade activation, and another pathway leads to bradykinin release. So coagulation cascade pathway will lead to DIC, will lead to hemorrhage, will lead to multi-organ dysfunction, and bradykinin will lead to relaxation of smooth muscle cells, which lead to uterine atony, which lead to decreased BP and uterine atony. Smooth muscle cell relaxation will lead to vasodilation, decrease in BP, hypotension, and atony. So on the one hand there is problem with the coagulation, on the other has problem with the bleeding. So both type of problems can occur in obstetric hemorrhage. It is a very challenging problem and needs a coordinated efforts. Thank you.